few endocrinologists in Mauritius.
I understand. Mauritius is a small place.
Yes.
Saptashi, did you receive my my slide?
Yeah, I've got it now. So I have all. I think Dr. Sela, you have got it, right? You got the slides.
Yeah, the intro slide I have.
Yeah, right. Thank you so much, ma'am.
Saptashi, next vacation is in Mauritius. Payal has told us you're welcome.
Okay. We can all go.
COVID-free, you're most welcome.
So once we are free from COVID after one year or 2 years.
Saptashi finishes the endocrine week, we are going.
You're all welcome.
Thank you.
So are we ready? So it's 4, right?
In 15 seconds, we'll go live.
Okay.
We are live.
Hi, everybody, and a very, very good afternoon to each and every one of you out there. A warm welcome on behalf of ESI to this very, very interesting third module of interdisciplinary endocrinology, where the theme for today's afternoon is going to be dermatological endocrinology. And to chair this session, we have an absolute galaxy of experts. We have who's Dr. Asit Mittal, who is the professor and head of the Department of Dermatology, R&T Medical College and Hospital, Udaipur. We have his colleague, Dr. Sonja, who's the head of the Center of Chronic Pruritus, professor for dermatology and neurodermatology, University Hospital of Münster, Germany. And we have our own colleague, Dr. Payal, who's an endocrinologist and secretary of Endocrinology and Diabetes Association from Mauritius. So that is a really universal flavor to the meeting today. A warm welcome to all the chairpersons. And now I will hand over the proceedings of the meeting to the chairperson to take it forward from here. Over to all three of you all.
So who would like to I think I'll take over it first. So a warm welcome to everybody. We as dermatologists are extremely pleased to be a part of this event, which is primarily an endocrinology event. But they have these interface meetings, and theme today is dermatoendocrinology. So I'm very thankful to my dear friend and colleague, Dr. Sonia Stander, who is a real great name in the field of dermatology and pruritus especially. So we have agreed to be one of the co-chair for this session. Thank you, Sonia. And Dr. Payal Chintaraman, who is, as you just said, an endocrinologist at Mauritius. So I think dermatology and endocrinology interface is very important because we do see a lot of endocrinal manifestations in the skin, and we are the first one to diagnose them at times. And secondly, I think a lot of things are coming up where a lot of receptors in the skin have been identified for lesion endocrinal hormones. Skin, in fact, has been told as one of the endocrinal organ which the people who deal with neuroendocrinology do not really recognize as such. But skin is an endocrinal organ in itself, with CRH and thyroid stimulating hormone being secreted from the skin. So I think that's great scope between the skin and great scope and interaction between the skin and endocrinology. Dr. Shoni would like to say anything as an introductory part to the event.
Thank you, Azit. I cannot say it better as you said it, and I'm also very pleased, extremely pleased to be part of this session and to get insights in your very interesting society and your topics. And I want to thank Azit and all the organizers here, and also Payal, my co-chair. So welcome from Germany.
Payal, anything from your side before we move on?
So yes, good evening, everyone. So thank you for having me, and I am also looking forward to this presentation because, as we know, there are different endocrinological disorders that have skin manifestations, and it is important that we're able to identify them and place a correct diagnosis. And it's important for doctors also to be able to, pinpoint from the skin manifestation what is going on, and perhaps make the proper endocrine diagnosis.
So the first on the agenda is, I think, the quiz, and it's been taken over by Dr. Shyam Sundar. So it's over to him now. I don't have Dr. Shyam's CV with me.
Sir, Dr. Shyam Sundar is an endocrinologist from Visakhapatnam.
Okay.
Yes, sir.
Over to you, Dr. Shyam.
Thank you, sir. So,
you can share your screen now. Yeah.
yes. Yeah, is my slides visible?
Yes, Shyam, they're visible.
Yes. Just a minute. Okay, good evening, everybody. First of all, I would like to thank the Endocrine Society of India and Dr. Maithili ma'am also for giving me this opportunity. So I'll directly proceed with the questions. So the rules are all the participants. Just a minute. To submit the answers before the end of the talk, and all the answers should be given at one go in a single message, and the answers will be given after the talk, and also add your name and place, and the winners will be announced at the end of the talk. Sorry.
Shyam, I think this is in a PDF format.
Pardon.
The wrong this is.
Sorry. I
just open it in the PPT format. I think that's the reason there's some issue. Just check that out. Don't worry.
Excuse me. Just one.
Yeah, koi na. Take your time.
Sorry.
Don't worry at all. We are all terribly, I know for a person, I'm terribly handicapped when it comes to some of the gadgetry.
It can fail you at very critical times at times.
It always does, Dr. Mittal. It always does, believe me. It's happened so often to me now. So yeah. I really understand the feeling.
Yeah,
thanks, Shyam. Please, yeah.
Yeah, is my screen
yeah, we are good.
Yeah.
Yes, absolutely.
So the first,
please.
Thank you. The first question is most common cutaneous marker of diabetes mellitus. The options are A, necrobiosis lipoidica diabeticorum, and B, cutaneous candidiasis, and C, shin spots, and D, scleroderma diabeticorum of Buschke. So the next question is, in Addison's disease, which of the following skin change is not seen? So option A is hyperpigmentation prominent over sun-exposed areas. B is vitiligo. C is increased axillary and pubic hair. And D is darkening of hair. And coming to the third question, it is Acanthosis nigricans can be seen in all except A, diabetes mellitus, B, hyperprolactinemia, C, acromegaly, and D, Addison's disease. So the next question is, fourth question. All are true regarding carcinoid syndrome induced scleroderma like disease except A, usually associated with foregut carcinoid, B, absent Raynauds phenomenon, C, involves lower limbs first, and D, hands and feet are usually spared. So the next question is, following dermatological manifestation is rare in Carney complex. So A, Lentigines, B, blue nevus, C, Café-au-lait spots, and D, cutaneous myxoma. So this question does not have 4 options, but it has a visual clue. So name the 2 eponyms of medarosis. I think one of the eponym is named after this image. So it is a clue. So you have to name both the eponyms for medarosis. So the next question is tricholemoma, cobblestone papules on lips, acral hyperkeratosis, and palmar pits in a patient with thyroid nodule and ovarian cyst. So the image shows tricholemoma just below the palpebral fissure and palmar pits in the image B. So the gene mutated in this condition is A, mTOR gene, B, PTEN gene, C, AIRE gene, and D is RET. So the next question is, histological appearance of stack lasagna is seen in, so A, necrobiosis lipoidica, and B, granuloma annulare, and C, acanthosis nigricans, and D, it is scleroderma. So this is the stack lasagna appearance seen on the histological section of the skin. So the 9th question is, all of the statements are false about the image except A, it is permanent in nature, B, appear at triglyceride levels between 250 to 500 milligram per deciliter, and C, accumulation of triglyceride in histiocytes, and D, pathognomonic of dis-beta lipoproteinemia. So the last question is, the proposed modification of a Ferriman-Galvez score involves all except A, perineum, B, sideburns, C, lower jaw and neck, and D, forearm and hand. So these are the 10 questions, and you have approximately 25 to 30 minutes to answer. And I hand over back the session to the chair.
Thank you, Dr. Shyam. So these quizzes, trivia are always difficult, actually.
Yes, I agree. Not the easiest questions. And even dermatohistology, I'm very impressed. Very interesting.
I
Yeah.
understand you have some special interest in dermatopathology.
Yes.
Yeah. So you really have to dig deep into your not exactly knowledge, but you have to just recall what exactly is. Okay, so we are on to the next on the agenda, which is a talk by Dr. Mithali, who is a very senior endocrinologist from Vizag. She is associate professor in the Vizag Medical College, I suppose. So Dr. Mithali would be taking this lecture. Over to you, Dr. Mithali.
Good evening, everybody. Well, I'm indeed honored to be a part of today's session. And I thank the Endocrine Society of India, the President, Dr. Sanjay Kalra, Dr. Saptarshi, Dr. Sheila, for the opportunity given to me. We are indeed privileged to have eminent dermatologists with us, Dr. Asif Mittal from Udaipur and Dr. Sonja from Germany. And I'm sure their presence and participation today in this meeting will enrich our knowledge on dermatoendocrinology.
Ma'am, full screen, please.
We are also eagerly waiting for the comments of our international endocrine colleague, Dr. Payal. And I appreciate Dr. Shyam Sundar for the excellent quiz he has conducted. Well, the chairperson has given a very, very nice introduction and a summary of today's topic. Then, as you already said, endocrine disorders often first present to the dermatologist. So the dermatological manifestation not only helps in diagnosis of the endocrine disorder, but also helps in monitoring the treatment of the disorder. So that's why the skin is called the mirror to the body. And then there are some of the common clues for a hormonal basis come from the skin as well as its appendages. So some examples depicted in this slide are, you can see a characteristic body odor of acromegaly, the dry hair of hypothyroidism, sweating disturbances like in hyperthyroidism, acromegaly, and even pheochromocytoma can be added here. Then hirsutism, all androgen excess states can produce a number of conditions. Alopecia and terogem, again, autoimmune markers and do occur with hypo and hyperthyroidism. Skin pigment abnormalities, ACTH excess and deficiency are responsible. A skin texture thickening is because of the anabolic actions of growth hormone and IGF-1 like in acromegaly. The skin thinning is due to the catabolic effects of cortisol as obvious in Cushing's disease, and then generalized pruritus in a number of conditions. So this we are aware for so many decades, but as the chairperson rightly said, the skin is now an endocrine organ. So there is a cutaneous endocrine system in the skin. So the skin synthesizes hormones, there are enzymes present, there are receptors present in the skin. To name a few, the 5-alpha reductase 1 converts testosterone to dihydrotestosterone in the skin, especially the scalp and the face. Then of course we have the thyroid and the androgen receptor. You can see TRH, CRH, MSH are all present in the skin and their receptors are also seen. The skin synthesizes IGF-BP3 in addition to the liver, and the PTHRP is also synthesized in the skin. So prolactin and vitamin D are also synthesized in the skin. So the prevalence of, well, I will confine, I'm not going to go into the dermatoendocrinology part, but I'll confine myself to the cutaneous manifestations of endocrine and metabolic disorders. So the prevalence of the cutaneous manifestations is quite high. If you look at the common endocrine and metabolic disorders, diabetes, 70 to 80% have skin manifestations. Thyroid disorders, 60 to 70%. And Addison's disease, again, almost universal skin manifestation. So the skin signs, again, which point to an endocrine disorder, they may be specific or they may be non-specific. So some of the common signs which we see are, let me start with Acanthosis nigricans. So this is again a picture of Acanthosis nigricans. So you can see a thickening of the skin and the nape of the neck, the hyperpigmented plaque-like appearance with a velvety feel. So many conditions of insulin resistance can produce Acanthosis nigricans. So one of the questions of Dr. Sham was Acanthosis is seen. Remember, in addition to acromegaly, hyperprolactinemia through increase in the IGF-1 can also lead to Acanthosis nigricans. Acne, again, a common skin disorder, a very important cosmetic problem, is again can occur in so many endocrine disorders, glucocorticoid therapy, Cushing syndrome, and all androgen excess states. Well, acne points to an endocrine disorder if it is occurring suddenly at a later age, and if it is resistant to conventional therapies, it is a good marker of androgen excess. Then, cutis verticis gyrata, a specific scalp disorder, again can be seen in acromegaly. This is again because of increase in collagen in the dermis, leading to buckling of the skin. Granuloma annulare is specific to diabetes. Hypertrichosis is seen in many endocrine disorders. Necrolytic migratory erythema is specific for glucagonoma, and so is scleroderma for diabetes. So these are some of the signs which point to endocrine disorders. Well, this diagram is the necrolytic migratory erythema, which is specific for glucogonoma. So I would like to discuss the cutaneous manifestations as per taking each endocrine organ dysfunction. So I would like to start with the pituitary. So the mucocutaneous manifestations of acromegaly, these are usually present at the time of diagnosis. So they're usually universal, they're present at the time of diagnosis. And they're all because of the mucocutaneous manifestations are because of thickening of the skin and the soft tissues. So macroglossia, macrochelia, gingival hyperplasia, coarse facial features are all because of the soft tissue and the skin thickening. Then hyperpigmentation in acromegaly is because of an increased pigment production. Acanthosis again occurs because of the metabolic syndrome. There is an increased sweating, there is an increased villous hair, and then you have a typical flat broad nails called as platynachia. So these manifestations of acromegaly do ameliorate to a certain extent when you treat the disorder. The disorder is cured. Then comes hyperprolactinemia. As I said, because it increases the IGF-1, there is a limited overlap in the cutaneous phenomena seen in acromegaly. The example is Acanthosis nigricans. And the typical manifestations of hyperprolactinemia are, as far as the skin is concerned, are the SAHA, the mnemonic for seborrhea, acne, hirsutism, and androgenetic alopecia. This is all because of an increase in the adrenal androgens. Hypopituitarism, the skin phenotype is dominated by the main hormone which is produced in insufficient amounts. So the ACTH absence leads to pale hypopigmented skin. GH and prolactin deficiency lead to skinning of the thin, a reduced sebum production, and reduced sweat secretion. So all this produces a picture of wrinkling of skin around the eyes and the mouth. And in addition, you have a decrease in the hair and the nail growth. Well, thyroid disorders, we all know that thyroid hormone is very essential for the skin, the keratinocytes of the epidermis, the fibroblasts of dermis, all they need the skin formation. We need the thyroid hormone. So is the hair formation and the sebum production. So hypothyroidism, again, cutaneous manifestations are quite obvious. So the dry skin, cold mottled skin is all because of vasoconstriction and because of the decrease in the keratin turnover. Then the classical cutaneous manifestation, the myxedema is the term given to the classical skin manifestations of hypothyroidism. In addition, macroglossia, there is a loss of lateral third of the eyebrows. Again, this was another question put by Dr. Shah. Madarosis, that's called the Queen Anne sign or the Hethoff sign. There is a coarse brittle hair, and beyond this, coexisting autoimmune disorders produce autoimmune urticaria, vitiligo, and alopecia areata. This is one of our patients. So you can see the typical myxedematous appearance. So untreated congenital hypothyroidism. We did have children like this. She was 20 years old when we saw her, maybe 5 years or 10 years back. You can see the periorbital puffiness, the fleshy lips, the supraclavicular fullness, very typical of myxedema. Well, the mucocutaneous manifestations of hypothyroidism do again resolve when we treat hypothyroidism. Moving on to cutaneous manifestations of hyperthyroidism. So they are all because of thinning of the skin and vasodilatation. So the warm, moist, smooth skin, flushing, palmar erythema are all because of the skin thinning and vasodilatation. There is an increased sweating. There is a diffuse scalp hair thinning, onycholysis, pretibial myxedema, thyroid acropathy is rare, generalized pruritus, and chronic urticaria. This is again a picture of onycholysis. So you can see that onycholysis is the separation of the distal nail plate from the nail bed. And this is what is called the dirty nails. It is first obvious in the 4th and 5th fingernails. I don't know the reason why. But then they do ameliorate when with treatment of thyrotoxicosis. Well, this picture is taken from the article Dirty Nails published in JCEM. Again, a very important series published in the JCEM is the thyroid dermopathy, a series of about 78 patients. And there were 5 different types of thyroid dermopathy which are described there. So the first picture A is the typical pretibial edema. B is the pretibial plaque. If you see C, you see nodules in the ankle, around the ankle and the feet. D is the elephantiasis, and E is scar, in a scar, dermopathy in a scar. So there are so many different variants of thyroid dermopathy. And remember that thyroid dermopathy is a very, very important extrathyroidal manifestation of Graves' disease. However, it doesn't go parallel with thyrotoxicosis treatment. You may treat thyrotoxicosis, but still the dermopathy may not resolve. So treatment is difficult. Mild forms resolve with topical therapies, but severe cases are resistant to treatment. Well, parathyroid glands, again important for skin health. The PTHRP is synthesized in the skin. There is a PTH and the PTH receptor signaling now identified in the skin, and skin hair nail changes are described with parathyroid dysfunction. Primary hyperparathyroidism, the symptoms are quite subtle. There's a mild pruritus, there's a dry skin and mucous membrane secondary to dehydration. Secondary hyperparathyroidism, because of metastatic calcification, can produce calcinosis cutis. These are erythematous indurated papules. So these, you can see the picture of calcinosis cutis with an ulceration, and usually seen on the extremities. Hypoparathyroidism, mucocutaneous manifestations are well described by Indian authors from Calcutta. Dr. Sakar S. et al. From India has published the mucocutaneous manifestation of acquired hypoparathyroidism in IJM 2012, quite high in as much as 76% of patients. So the skin changes are xerosis, pellagra-like hyperpigmentation, pustular psoriasis, and an acne-like eruption. Hair, you find loss of axillary pubic hair, coarsening of body hair, and alopecia. Nails are brittle, ridged, and there can be onycholysis. Well, the adrenal gland, again, the classical syndrome of hypercortisolism is the Cushing syndrome. So the skin manifestations of Cushing syndrome are all because of alteration in the subcutaneous fat deposition. So the moon phases, dorsocervical fat pad, the supraclavicular fat pad are all because of the subcutaneous fat deposition. This is one of our patients. You can see the typical moon face-like appearance. Then the facial plethora, easy bruising, delayed wound healing, skin atrophy are all because of thinning of the skin. The skin atrophy is the breakdown of the collagen is responsible for all these features. And hyperpigmentation occurs because of an excess of ACTH in ectopic ACTH syndrome and Cushing's disease. Acanthosis nigricans, again because of metabolic syndrome. Well, steroid acne and hypertrichosis are also other manifestations. Well, this is a picture of striae. You can see what is important about the striae are the striae are violaceous purple. You can see they're more than 1 centimeter in width. This is again another girl who came with hypertrichosis, which is obvious on her face. She received injections she and her sister, both of them received Kinocort injections from a general practitioner, and this was the concern for which they came. Well, Addison's disease, again, mucocutaneous manifestations are universal. There's a diffuse cutaneous hyperpigmentation, especially the sun-exposed areas. So there is pigmentation of nevi, there is pigmentation of hair. Again, a question of Addison's was posed by Dr. Sham. Remember that hair hyperpigmentation is a feature. There is also repigmentation of the gray hair also. And then mucosal hyperpigmentation. There is loss of axillary and pubic hair. This is because of the absence of the adrenal androgens. And there are longitudinal hyperpigmented nail bands. Again, one of our patients showing the the buccal pigmentation on the tongue and the lips. So the mucosal pigmentation can be a marker, can be a sensitive indicator of the monitoring therapy. Pheochromocytoma, dermatological manifestations are rare. It is usually an intermittent facial flushing, hyperhidrosis, and a paroxysmal facial pallor. But however, fixed lesions have been described like aggravation of Raynauds phenomenon and libido reticularis. So this is again a publication in JCEM which showed libido reticularis in the figure A, and on treatment of pheochromocytoma, there is amelioration of the libido reticularis. Well, ovary, again, estrogens are important for the 17-beta estradiol, also is important for the skin texture and the skin health. So hyperestrogenic states where women use oral contraceptives, phytoestrogens or estrogen-producing tumors can have melasma, telangiectasis, and candidal vulvovaginitis. Hypoestrogenism, like in menopause, can have female pattern hair, balding, and skin changes. Well, cutaneous manifestations of androgen excess in women. We are all aware that is hirsutism, and then acne vulgaris, as I said, is an important manifestation. There's a female pattern hair loss. This is the term now used for androgenetic alopecia. So you can see the thinning of hair on the vertex in this patient. And of course, seborrhea is again due to increased sebum production by the androgens. Again, one of our publications was this postmenopausal lady who came with hirsutism. We evaluated her, the case of a Leydig cell tumor of the ovary, and a very rare association was she had a primary hyperparathyroidism. Of course, the hirsutism and decreased after surgery was done. Well, testis, androgen receptors, receptors are there in the skin, and as I already said, androgens maintain the skin thickness, the hair on the skin, and the pigmentation of the skin. So hyperandrogenic states, you do have an increased skin thickness, hair, and pigmentation, and the reverse happens with hypogonadism, where you find the skin is smooth, soft, and there is absence of hair. So the next, I move on to multiple endocrine syndromes. So these syndromes are important for us because the cutaneous features often help in identifying these syndromes. The endocrine manifestations come later. And the reason for the cutaneous manifestations are the specific genetic mutation in these syndromes. So we'll discuss this under the tumoral syndromes and the non-tumoral familial syndromes. So the tumoral syndromes with skin manifestation, I start with the MEN1 syndrome. So the endocrinopathies of MEN1 are parathyroid, pituitary, and pancreatic tumors. So the classical dermatological lesion that is described is the facial angiofibroma. And then this is present in almost 80 to 90% of cases of MEN1. It precedes the endocrine manifestations, and the less common are the collagenomas and lipomas and neuromas. A coexisting hyperparathyroidism produces calcinosis cutis, and then of course flushing due to carcinoid and necrotizing migratory erythema if there is a glucogonoma. So this is again a picture of the facial angiofibromas. You can see the fleshy papules on a number of them on the nose and then the face. And the lower picture is the collagenomas. So the picture is from JCEM article. So very important is more than 3 facial angiofibromas plus a collagenoma has a very high sensitivity and specificity for diagnosing MEN1 even before the endocrinopathies evolve. Well, then MEN2A cutaneous amyloidosis. So this is a picture of cutaneous amyloidosis. So the picture is taken from the article published from the All India Institute of Medical Sciences, Delhi. The article is a rare manifestation of MEN2A and cutaneous lichen amyloidosis in a family with RET mutation. So the mutation, the RET mutation, which has a mutation at codon 634, rarely is associated with amyloidosis. But however, this particular family had that mutation, and they did have amyloidosis. Well, the same picture is you can see in Williams' textbook of endocrinology. This is another patient of ours who had, you can see the ganglioneuromas on the lips and then the tongue. So then other tumors are the tumors which have tumoral syndromes which have Café-au-lait as the skin manifestations. So the differential diagnosis usually is between a McCune-Albright syndrome and neurofibromatosis 1. So the Café-au-lait spots of McCune-Albright syndrome have a ragged edge comparable to the coast of Maine, and then they do not cross the midline. They have their segmental in their distribution. Whereas neurofibromatosis 1 have a number of Café-au-lait spots, the coast of California having a regular edge. There are more than 6, and then you have so many other cutaneous manifestations like neurofibromas and iris hematomas and nevi. So the Lentigines and endocrine syndromes, we have examples here, the Leopard syndrome, the Carney's complex, and the Cowden disease. So these are all syndromes which have a spotty skin pigmentation associated with the endocrine hyperactivity and then endocrine and non-endocrine tumors. Again, there is another question which I would like to answer here. This is the Carney's complex. What is rare in Carney's complex is Café-au-lait spots are rare. So the common ones are Lentigines, blue nevi, and cutaneous myxoma. The non-tumoral familial syndromes, the skin manifestations are the autoimmune polyendocrine syndrome 1. This syndrome is there is a hypoparathyroidism, adrenal insufficiency, and hypogonadism, hypothyroidism. So, this particular syndrome, the very important cutaneous manifestation, again, almost universally present is the mucocutaneous candidiasis. So it precedes again the endocrine picture. So this is a picture showing the fungal infection of the nails and the paranachia. Then alopecia areata and vitiligo also occur less commonly. So this is again one of our patients with alopecia areata and coexisting hypothyroidism. So treating hypothyroidism does resolve alopecia areata to a certain extent and in some individuals. So the autoimmune polyendocrine syndromes 2 and 3, there's only the hyperpigmentation due to adrenal insufficiency. And then there are other syndromes like the AHO and the tuberous sclerosis, which also have a combination of dermatological lesions and endocrinopathies. So a word about vitiligo and the increased prevalence of thyroid dysfunction and diabetes mellitus in Indian vitiligo patients. So Indians do have, it is important that vitiligo patients be screened for thyroid and diabetes disorders. Well, the last part of my presentation is about diabetes and lipids. So the cutaneous manifestations of diabetes are because of hyperglycemia, hyperinsulinemia, and microangiopathy. So there are a number of cutaneous manifestations which all of us are aware. The most specific, though rare, is the necrobiosis lipoidica. So this is a very typical picture showing the necrotic erythematous lesion on the leg, and this is the histological picture. What Dr. Sham said is the stacked Lasag appearance. Then diabetic dermopathy is the most common cutaneous. Maybe if we leave infections, I think diabetic dermopathy is the most common cutaneous manifestation. Again, diabetic bullae are rare, but of course they are specific for then scleroderma again occurs with diabetes, acanthosis, carotenemia, lipodystrophy, hemochromatosis, and xanthomas and infections. So this is again our patient. This girl had lipodystrophy, which is very obvious. You can see the prominence of musculature, absence of subcutaneous where she had diabetes. A very important for endocrinologists is to examine the insulin injection sites for lipohypertrophy, especially in children, type 1 diabetes children taking a number of insulin shots daily. So, this is again a very interesting case which we had. So this boy was a type 1 diabetic who was attending our department for the last 10 years. So his presentation was with the Norwegian scabies. These pictures have been shared by our dermatology colleague, Dr. Raghu Rama Rao. You can see the isolation of the itch mite. It's an extensive crusted scabies. The boy was treated successfully, and last week, this is his picture when he came to the OPD. So finally, lipid disorders also have cutaneous manifestations. The hypertriglyceridemia and this beta lipoproteinemia have eruptive xanthomas as obvious on the knees and the elbows. So you can see the yellowish papules with an erythematous base. So this is eruptive xanthomas. And of course, familial heterozygous hypercholesterolemia again presents with a number of xanthomas like the tendon xanthomas and the tuberous xanthomas like in this girl. So I think with this, I have finished my short presentation, and I'm sure whatever I have missed or will be added by our expert panelists. So the take-home messages of today's presentation is dermatological features provide important clues to associated endocrinopathies. The skin findings may be a hallmark lesion. They may be the first clinical sign of the endocrine syndrome. The very complex interplay between hormones and skin. So the subject dermatoendocrinology is going to be the future. And skin as an endocrine organ may provide new avenues of endocrine disorder management. Well, once again, I thank all the expert chairpersons for listening to me. I thank the delegates and I thank the host for this opportunity. Thank you.
Yeah, thank you very much for this excellent presentation and excellent overview. I really enjoyed listening to you and watching also the wonderful images you showed us. This was really very representative and a great overview. So, Azit, what do you think? Maybe there are some questions from the audience? Or Payal, do you have a comment or questions?
No, thank you, Dr. Maitali. That was very informative, and the pictures were great. And certainly, it's a good reminder of watching out the skin when you're examining your patient, and to look out for other endocrinological disorders.
I maybe have only a very small question. In dermatology, we have a little issue with this cutaneous amyloidosis. So we avoid using this term because we don't want that our colleagues do gastrointestinal biopsies to rule out systemic amyloidosis. Okay. So Azit, we prefer the term notalgia paresthetica, but it's a synonym, of course.
Okay.
Yeah. Did you know this term, notalgia paresthetica?
No.
Yeah. So that's the beauty of having two disciplines together and exchanging ideas. So, but I think it's really a problem in dermatology. You know exactly that it's not a systemic amyloidosis. Azit, you are we cannot hear you.
Yeah. So I think I agree with you that sometimes patients confuse amyloidosis with something very severe. Well, cutaneous amyloidosis is a pretty mild disease. We know that amyloid is derived from skin proteins, keratin, either because of scratching, what Shoni was saying, notalgia paresthetica, it's a kind of entrapment neuropathy which produces localized itch. And when patient rubs, itches, produces those pigmentation which you were referring to, the pigmented streaks. So the other thing I would say that you talked about acne and androgen axis.
Yes, sir.
Over the years, we are seeing a lot of maturity onset acne. Maturity onset means acne starting beyond 25, 26, not in the usual acne age. And those are the patients where we suspect that some kind of endocrine imbalances occurring. May not be the true circulating levels might not be increased, but end organ responsiveness is definitely increased. I mean, the skin producing more 5-DHT and more acne kind of things. Okay. So, and in the same thing, perhaps people believe that the exogenous source of hormones could come from milk or dairy products. Okay. So So a lot of these Western diets that have those milk and dairy products, which probably produce more IGF-1 and leads to more acne. So both endogenous and exogenous source of acne, of hormones, androgens, causing maturity onset acne is something. I would just like to ask from Sonia, that what is your take on diabetes and pruritus? Do you feel that each is generalized in diabetes or it's more localized each in diabetes?
That's a great question, and thank you also, Dr. Mutili, to refer always to pruritus. So we see more generalized pruritus in diabetes, in fact. So it starts frequently on the back, and there is a very good paper referring to the origin being neuropathic. So in fact, we try to find if there is a kind of small fiber neuropathy in these patients or signs of neuropathy. We even do skin biopsy to count the nerve fibers that cross the basement membrane, so the intraepidermal nerve fibers. And this is frequently the explanation of pruritus associated with diabetes. And so we apply gabapentin, and in many cases it works very nicely. So this is a little bit oversimplification, but in fact, when you look in the literature, there is not in-depth science, and this is something what we are also interested in and work on this. Funny enough, with our neurologist, but not with our endocrinologists.
So, Sonia, I want to tell you that me and Dr. Kalrao, who is the president of Endocrine Society of India, we've been working on diabetic itch, and we're doing a sort of study together on diabetes itch. Maybe we'll be able to add something more to the diabetes itch.
Yeah, so absolutely. And please, if you want to examine the nerve fibers, let me know if I can be of any help in this issue.
Sure, thank you. So, Dr. Pyle, anything you want to add before we move on to the answers for the quiz?
Yes, regarding pruritus, many of our patients with diabetes, they complain of the pruritus. It's not necessarily related to hyperglycemia, like high blood sugar. It may also happen that there's just at the onset of the diagnosis of a mild hyperglycemia, the patient experiences pruritus. And it's very difficult to manage. We tend to prescribe all sorts of ointments and lotions and, tell them try to, get your diabetes under control if it's uncontrolled. But yes, a very common manifestation here also.
Mm-hmm. The other thing is we often talk about the necrobiosis lipoitica diabeticorum as a manifestation of diabetes. I have yet to see a single case of NLD in India, at least. So, Shwani, do you see NLDs in Western world more or what? I think in India, it's not seen very commonly.
We see a lot of necrobiosis lipoitica, yes, in especially in young patients when there is a early onset of diabetes. Diabetes 1.
But I think most of my, we don't have any more Indian colleagues here, they would agree that we don't see that very often. There could be some kind of a difference in manifestation there.
Yeah, that could be in fact an ethnical difference, as we also know for other dermatoses. And this is a research area that just has begun. For example, also in atopic dermatitis, when you go in different parts of this world, you see different manifestations of atopic dermatitis, and they are now the first good analysis for that. So that's really interesting.
If I can ask the dermatologist, so how is your experience related to gliptins and DPP-4 inhibitor induced pruritus? So it is emerging as a cause of, it has been recognized as a cause of bullous pemphigoid, and we keep on seeing these patients in our practice where they come up with very intense itching, and we stop that medicine, and it actually, so bullous pemphigoid has been reported, but in clinical practice we see quite a lot of variable dermatological manifestation with this molecule.
Gliptin-induced itch, Shona, have you seen gliptin as a cause of itching only and no bullous lesions or nothing? I haven't seen itching.
No. Maybe it's a drug reaction. I'm not sure. So I don't have a lot of experience with that.
Bullous pemphigoid itself is a pretty itchy condition. So
yes, I mean that's common. We see this every day, but this special question of this molecule-induced itching and bullous lesions, not very often.
If I may add, we do tend to prescribe gliptins here, a lot of gliptins, and while I haven't come across of itching associated with gliptins, but rather I had one case of hyperpigmentation when the gliptin was started, and then we had to stop the gliptin. But then the hyperpigmentation of the face took a very long time to just go away. So I went for a search of literature. It was it was one of the adverse reactions associated with gliptins.
yeah, the other thing is that even if it is gliptin-induced, say, bullous pemphigoid, there's not a guarantee that once you withdraw gliptin, it's going to go away. So it could be either be gliptin aggravated. In that case, the patient has already got a is prone for bullous pemphigoid. Yeah. And the other one is the gliptin-induced it. So that's not very common, I think. Literature does say that gliptins and bullous pemphigoid have a very close relationship.
Interesting question.
I can't see any questions on the chat, in the chat box from the participants.
So we could possibly ask Shyam to discuss his answers, sir, if that is okay with you.
Yeah, I think it is.
Shyam, you want to go ahead and answer the difficult questions that you have just posted for us?
Sure, ma'am. I'll share the answers. So, is my screen visible?
Yeah.
Visible.
Yes, thank you. So, the answer to the first question is, most common cutaneous marker of diabetes mellitus is shin spots. As you know, necrobiosis lipotica diabetica is the most specific cutaneous marker, but the most common cutaneous marker is the shin spots. And in Addison's disease, which of the following skin change is not seen? Yes, as you know, hyperpigmentation is common, and vitiligo, because of the autoimmune nature, it could be there, and darkening of the hair, like Madam told, the gray hairs also can, again, darkening can be seen. Pigmentation of the gray hairs also can be seen, but the increased axillary or pubic hair is not seen in Addison's disease. So this is one of the images where there is hyperpigmentation of the nail beds as well. So acanthosis nigricans can be seen in all except. So this is a straightforward question. The answer is Addison's disease. Other three conditions, because of the insulin resistance, they have acanthosis nigricans. And all are true regarding carcinoid syndrome, induced scleroderma like disease except. So the answer is, it is usually associated with the distal hindgut carcinoid. So the scleroderma-like disease is considered a feature of carcinoid tumor arising from the distal ileum, and the substance P and neurocanine A are exclusively produced by the terminal ileal tumors and are therefore more likely mediators. And it tends to involve the lower limbs before the upper limbs, and generally spares the hands and feet. So following dermatological manifestation is rare in Carney complex. If we see all the options are possible in Carney complex, but Café-au-lait spots are rare. So this is one of the article in European Journal of Endocrinology where there is Carney complex update. So it is a beautiful article. In that they have mentioned the Lentigines, blue nevus, and cutaneous myxomas are seen more commonly, and Café-au-lait spots are rare, and depigmented lesions and Spitz nevus, they are rare compared to the other features. So the next question was the two eponyms for medrosis is the Queen Anne sign. She was the Queen of Denmark. If you can see the loss of lateral part of the eyebrow, and also it's also known as the Hertog sign, named after a Belgian internist, Christian Hertog, and it is commonly seen in hypothyroidism. And Palmar-Pitt's tricholamoma in a patient with thyroid nodule and ovarian cyst. It is seen in Cowden syndrome, and the most common gene mutation seen is PTEN mutation. So it is a multiple hamartoma syndrome. It was first described by Lloyd and Dennis, and the patient's name is Rachel Cowden. So this syndrome is named after a patient called Rachel Cowden, and the doctors who identified was Lloyd and Dennis. So there are various criteria, and the pathognomonic lesions are tricholemomas, acral keratosis, and facial cutaneous papules. Papillomatosis of oral mucosa is also seen. And the histological appearance of stack lasagna is seen in necrobiasis lipoidica diabeticorum, and a layer of inflammatory process and alternating zones of necrobiosis involving there is the full thickness of dermis is involved, and the changes tend to become more pronounced in the deeper layers of the dermis and may extend to the septal paniculatus. And the areas of necrobiosis are poorly defined and run into each other with broad foci of inflammatory infiltrate, and this giving the appearance of stack lasagna. And all the statements are false about the image except. So all are false, and only the true statement is accumulation of triglyceride in the histiocyte. So this is a direct question from Williams. And these eruptive xanthomas are transient in nature, and they resolve with treatment. And the triglyceride levels between 1,000 to 2,000 milligram per deciliter, and it is not pathognomonic of this beta-lipoproteinemia. Rather, Palmar xanthomas are pathognomonic of this beta-lipoproteinemia. And coming to the proposed modification of Ferriman-Galloway score involves all except. So the answer is forearm and hand. So if we see, as we know, the 9 areas are already present in the Ferriman-Galloway score. The proposed modification was to include the sideburn area, the lower jaw and neck, and also the perineum, which is missing from the Ferriman-Galloway score. So these are the answers, and Dr. P.S. Gargari from Kolkata has got 7 answers correct, and Dr. Devaditya Das from Kolkata has got 6 answers correct, and Dr. Ganesh and Dr. Shruti stand third with each 5 answers correct. So I hand over to the chairperson.
Thank you, Dr. Shyam. I think for making us wiser, for teaching us something. Thank you.
No, sir.
Some of the questions you start.
Yes, sir.
You don't remember sometimes these things. And the lecture was excellent, I think. I must say, this was, very, very concise, and you told everything in a very short time.
Thank you, sir. Thank you so much.
Can I ask a question? So this is really profound dermatological knowledge. Do you have regular exchange with dermatologists, or is this that you learn it during practice, or how do you manage that?
My wife is a dermatologist, so we both exchange the good.
So then one can understand that you have.
Dr. Sonja, we really have a good relation with dermatologists. Endocrinologists do have a good relation with dermatologists in India.
Yeah,
Very
I
good.
agree that it's probably a universal thing. Is it so in your place also? A lot of interaction between dermatologists and endo people? Sonia?
Yeah, when we need it. It's not on a regular base, but if there are complex cases, so we have exchange with endocrinology, rheumatology more. We have all these autoimmune disease like lupus erythematodes, and so we really need to work close together. But for example, in our hospital, we have someone, Markus Böhm, Professor Böhm, who is specialized on dermatoendocrinology. So it's fascinating, and he also makes research about the sebaceous glands and that they release beta endorphins and something like that. So it's really fascinating, the microcosmos of endocrinology in the skin, as you said, Azit. But also, I think your knowledge is amazing. I'm very thrilled and surprised, and yeah, it was really great to be a part here.
Yeah, thank you.
I think for all of us, for dermatologists, for all dermatologists, maybe two we are here, it was an experience. So thank you very much for inviting us, for giving us this opportunity to be part of this collaborative.
Thank you.
So we want to actually say thank you to all of you all for really being a part of our knowledge enhancing experience. To be very honest, this has been the brainchild of our president. And we realized as endocrinologists that sometimes you really need to associate with other disciplines to be able to treat our patients better. And that is the final aim of the entire meeting, that we all learn from each other and hopefully we can all be better clinicians. So, I mean, a big thank you to all the three chairpersons, Dr. Asid, Dr. Payal, Dr. Sonja. We really appreciate the time taken. A big thank you to Maithili ma'am. I learned a lot of things. I mean, I'm going to look at the skin more carefully henceforth, definitely. I mean, sometimes as a clinician, as an endocrinologist, you tend to become so much like a horse with blinkers. You don't tend to really realize that, you know, the skin could tell you so much. And Shyam, thanks a million for your excellent questions. Saptarshi, as we all know, is my partner in crime. We are. I love working with him. And
Thank you,
once
ma'am.
again, a big thank you on behalf of ESI to each and every one of you all. Thank you very much.
Thank you.
Before
Thank you,
winding up, I
Shyam.
would again like to appreciate all the good work that Endocrine Society of India is doing and for involving us into this. Thank you.
Thank you.
Thank you.
Thank you.
Thank you, and bye-bye. Have a great
Thank you,
day.
everyone.
Evening,
Have a great
morning,
time.
whichever part of the world you belong to.
Yeah.
Have a great day.
Yeah, take care. Take care.
Yeah,
Take care.
thank
Be
you, sir.
safe.
Thank you with us. Thank you.
Thank you, everyone.
Bye.
Bye.
Bye. Bye.
Bye, Azit.
Bye.
Bye-bye.
Please take care.
Bye-bye.
Yeah. Bye.
Take care, you too, and many greetings from Hartmut.
Yeah. Thank you. I was just wondering if I could bring Reena and she might say hello to you in person, but I think she's there.
Okay.
Okay.
Yeah.
She was asking me, Sonia, how long she's going to stay. For 1 hour. The program is 1 hour.
That's it. Yeah. Yeah, but good to see that you are well, and Rina also.
Yeah, me too. Maybe me too. Yeah, we were just wondering that things are really, they're not good all over. So
yeah,
we hope that all of you keep safe and healthy.
Yeah. Hartmut had to be 2 weeks in quarantine because in the hospital was a positive patient and they didn't know, but he didn't get an infection, and that's good.
So that was precautionary.
Yeah, it was precaution. And here's a lot of precaution. So we have to close several of our surgery theaters at the central department, not in our department, because some of the staff were positive. So it's coming closer now also to us.
So at our place, I mean, they actually took our place, they took our department into COVID, the building, our building. We had to move to a different place. Because there were a lot of COVID cases at that time. So the whole of our building, we had a separate skin building. They took our inpatients and everything.
And do you have now an equivalent building? What is
no, it's not
good
not,
or?
No, it's definitely not of same order. But you have to bear with it. I mean, you can't do much. So hopefully, in next 3 months, 6 months, as things improve, we might move to our old place.
And do you have a vaccination at the horizon, or are you also waiting?
We're waiting, but it seems that Serum Institute of India, which I mean, it's a place in Pune, in India, and they are collaborating with Oxford Vaccine also, and probably saying that December and January first week you might have it.
Yeah. So you think you will have it in when?
I'm not sure, but people are saying, government is saying January, but
January. That's quick. We don't expect it to have it in January.
Me too. I think it should not be before second half, maybe April, March, possibly.
Yeah. Yeah. And are you losing a lot of money now because of the movement of the department?
Not, I mean, money in what sense? Basically.
So we earn our money with inpatients, for example, and we had a shutdown in March, April for 5 weeks. And so we did not earn money, and our university is now in bad condition, of course.
No, but our place is slightly different. We don't earn that much from those inpatients. So the system is slightly different here. We don't charge from patients usually.
Okay.
Very
Yeah.
nominal charges being taken.
Yeah.
So on that account, but we have lost our ward. So now we have a very smaller ward. So if we have to admit patient, it's a problem.
Yeah. Yeah, this is also here. So many shops and restaurants are closing, and we know that they never will reopen. So and some companies take us to make their business smaller. Other companies, they are going bankrupt. So we are worrying a lot about Lufthansa at the moment. We don't know where they will end.
The same here. I think Udaipur is more of a tourist place. So a lot of restaurants, a lot of small hotels have closed.
Yeah.
I mean, they have to shunt out most of the people, most of the staff. They're just not meeting their recurring expenses also. So it is a real calamity. It's a real shock to people.
Yeah, it is really. So the world is changing completely.
Absolutely. Means besides the human loss, the economic loss too has been huge.
Yeah. We can be happy that we have a good profession that is needed.
Yeah, absolutely.
Yeah.
A lot of my residents too have been posted into COVID. Of course, they didn't post us, but a lot of junior staff has been posted into COVID.
Yeah, but no conferences. So the last time we met in Australia, you cannot think about it now. It's 1 year ago, and now it's so unrealistic.
But the things are, you never know when they are going to return to normal. So it's very difficult.
Yeah.
I think 2021, I don't see much hope. Possibly this will go like this.
Me neither. I think maybe. So I'm imagine, when do I travel next to United States? And I think 23 maybe. So I don't see it at the moment.
I mean, it's slightly more optimistic. 22 should be okay. 22 should be okay.
We will see, Azit.
That's why I thought that maybe I'll ask you if you can join us, because at least this will give us an opportunity to say hello.
Yeah, no, it was very kind of you inviting me, and I really enjoyed it. So they are very well trained.
Yeah.
Very good.
And these are they are actually having this interdisciplinary meeting with different departments. I mean, last week they had hepatobiliary people. So all these things they're doing. So the president of this society happens to be a good friend of mine. So.
Yeah. So thank you again.
Pleasure.
Yeah, it was good to see you. So many greetings again to Rina.
Same here.
Yeah.
To my side as well. Say hello to Ahmed.
I do, yes.
Stay healthy. Yeah.
I do. Azit, bye-bye.
Bye. Take care. Bye.